Hello, everybody. Thank you very much for the organization of this stimulating workshops. That's quite a challenge to be able to keep everybody in the same room, both clinicians and statisticians. So we tried the challenge of making a two voices talk with Weishi Chen on how to find the right dose of a novel cancer treatment.
On a case study of CAR T-cell therapies.
Okay, so we will try to make it lively, and this came from a question from Dr. Marion Alcantara, a very good hematologist who works on peripheral T-cell treatments. And as you may know, there has been a revolution a few years ago with the emergence, with the discovery of CAR T-cells, first in acute leukemia and then in lymphoma. And there is this very famous picture of a child that was about to die in a few weeks, and 18 years later, she is alive and perfectly well. And there were two major trials, Zuma 1, Juliet, both phase 2 trials, single agents, that came to approval of CAR T cells due to exceptional response rate, long duration of responses, but also some adverse events. And one of the most typical adverse events is what we call cytokine release syndrome that was observed in between 10 and 20% of patients that were treated. And to continue, at Curie, they have developed a new way to propose this CAR T cell, so to create this CAR T cell, and we'll come back to that in the next slide. And they have been able to use it as a compassionate use in acute lymphoblastic leukemia, and they wanted to use it in a rare lymphoma, that is brain lymphoma. And at Curie Institute in Paris, we are the national center for that. So it is a rare disease, but most of the patients will come to this center. So how does it work? The CAR T cell is a very sophisticated manufacturing process, because you remove the T cells and you engineer the T cell in order to direct the T cell against a specific antigen that would be expressed at the surface of the cancer cell. So the idea is that you take the cells, you make them multiply in vitro, and then you reinfuse the cell in the body of the person. How many cells do you infuse? This is something which is a bit esoteric. So they have come up with 3 dose levels. And I'm not even sure that they know how many cells they infuse, because of course many of them will die, but they expect to infuse some millions of cells, and they have defined 3 doses. What is important here is that we have absolutely no idea whether we are at the beginning of the dose activity, dose toxicity region curve, in the middle, or at the higher values. But that's the same thing, whatever the treatment based on CAR T cell is. So how does it work? The idea is that you infuse the cell, and as this is a living agent, they will start to multiply out. They will start to multiply. And so when you look at the time since infusion, you may expect to have this peak in individual patients. So here, each line is the evaluation of CAR T cells, the number of CAR T cells over time in a different patient. But in several cases, it will die without multiplication. And after a few weeks, usually you do not detect any more CAR T cell in the body. What is amazing, especially in acute leukemia and lymphoma, is that a single injection completely changed the course of the disease. So even after exhaustion of the CAR T cells, at least in the peripheral blood, they had very long and even long responses and either cure rate. So the question is, how do I design my phase 1 clinical trial? My first reaction as an old statistician nowadays, we made this PhD with John Quigley, was say, okay, let's go for the continual reassessment method, or we could have used the Boeing method. But keep in mind that in this case, we make this very strong assumption that you saw yesterday: the more you increase the dose, the more activity you will get, the more toxicity you will get. And John Quigley proposed this nice method, saying, okay, let's target the maximum tolerated dose and not the minimum active dose, because we will not see often activity in our patients, usually. Let's fit a simple non-monotonic model of the dose toxicity relationship, estimate the risk of toxicity, and allocate the patient at the best estimate. What is important here is that your very simple model here will work asymptotically. It will converge to the right MTD. It will enable you to find the right MTD if you sample most of the patient at the MTD. And we will see that later on, especially at the time of the Optimus project, where we would like to have a better assessment of the relationship between the dose and the toxicity, this kind of model might be quite restrictive. Okay.
So the CRM was a good method to find the MTD, but due to the following features of the CAR T cells, the MTD has almost never been reached. So the first feature of the trial is that, the sample size of is almost always very limited, so less than 15 patients. And also, as Xavier just mentioned, the mean toxicity is the CRS, and this is often manageable and reversible. So we don't really see the DLTs as the conventional toxicity endpoint. And due to these two reasons, we don't reach the MTD. But then the question is, do we really need to go to the MTD? Yeah, so in this review paper, it reviews the ongoing phase 1 trials on CAR T cells. For this bar chart, on the y-axis, we have the number of trials, which shows positive dose toxicity or dose efficacy relationships. So in blue, we have the efficacy, and in orange, that's toxicity. And different panels shows different types of the CAR T trials. So the monotonicity assumption basically means that we will want to see high values of both of the bars in both colors, which would suggest that the MTD will also be the optimal active dose. But from the plot, you see that we rarely have both bars to be high simultaneously. And this suggests that we probably shouldn't go for the MTD, and instead we will have to consider the toxicity and efficacy endpoints simultaneously. So one of the popular designs that considers both toxicity and efficacy endpoints is the FTOX design, which has a binary toxicity and efficacy. So in the model they proposed, they have a toxicity model which has 2 parameters, an efficacy model which has 3 parameters, and then they link these 2 elements to model the interaction between them using 1 more parameter. So in total, we have 6 parameters, but for CAR-Ts, we see that the sample size is very small, so we'll have to estimate the 6 parameters with less than 20 patients, and this can be really hard. So in the paper suggested by Tao and Cook, these 2 elements has been linked using the utility function. So these utilities are elicited from clinical informations. As an example, for this point pi1, which is a dose level that we ask the clinicians if, by the way, on the y-axis, that's the probability of toxicity, and on the x-axis, that's the probability of efficacy. So at this point, we have no toxicity and efficacy probability 1, so that's the best point we can get. And on the other hand, this is the worst point we can get. So this pi1 point basically asks the question that if there's no toxicity, what's the minimum acceptable efficacy that we're happy with? And similarly, we could ask a similar question for pi2, where we say that if we have maximum efficacy, what's the toxicity we're happy to tolerate, so on and so forth. So in this way, we could define a utility for any dose levels and put them in this plan. And in that way, we unite the toxicity and efficacy together. So we enroll the next patient to the dose level that maximizes the utility. So for the FTOX design, it will work well when the expected objective response rate is high. And then because we have so many parameters, it is flexible enough to model any dose toxicity relationship. But on the other hand, this design is sensitive to single observations, and also it implicitly assumed that increasing the dose level will increase both the toxicity and efficacy. And with that.
Okay, so you saw that we first dropped CRM because we said that a single endpoint toxicity was not an appropriate endpoint to derive the optimal dose. Then we went to FTOX, which is attractive, but probably completely unrealistic when we have so few patients. Why do we have only 15 patients? Because the cost of the treatment is just insane. 120,000 euros, at least in France, and the United States is $300,000 for one infusion. So of course, when you're an academic center and you want to make a trial, you cannot go for 40, 50 patients. Next, if we reconsider this meta-analysis on the correlation between endpoints, we see that it is not clear that we have a dose-response relationship. Most of the trials just look at a few number of dose levels, so making it very difficult to see whether or not there was an increase in activity or an increase in toxicity when you increase the dose. But still, it is not very convincing. We probably have more CRS when we increase the dose, and even that is not completely clear. The only thing that the authors tried to come out as a conclusion is that when the disease response, toxicity, and adverse event severity were clearly associated with CAR T-cell expansion. And that will be the next point, and I think it's also probably the most arguable element that we will present after that. So just to come back, we have here the days after CAR T-cell infusion. This is taken from a paper. You have the references in the end. Dose level 1, dose level 2, this is the mean value of the number of CAR T-cells in the circulating blood. And you have this kind of trajectories, and we might imagine that we could differentiate the two dose levels based on this continuous endpoint that is repeated. Here, what is really important is to say, okay, when you have a binary endpoint, response yes, no, when you have a binary endpoint, toxicity yes, no, the amount of information that you can take out of that is quite limited. We need more sensitive endpoint, and maybe expansion of CAR-T is a more sensitive endpoint in order to be able to rank the doses, to know what is, if we have, when we increase the dose, do we increase the expansion and the activity? So what do we have in our toolbox as statisticians? There is an old paper, early 2000, that tried to combine toxicity endpoint and a biomarker value. So I will not enter into the technical details, but you can find it in this nice reference. But the idea is that we have a biomarker that is linear, that is continuous. We assume it to be normally distributed after some transformation. That will be here the mean value of the CAR T cell at a given dose level in a given patient. Second thing, to combine it with a binary outcome, they propose to use a trick. The trick is a latent variable. You know, when you have a binary variable, you can find some kind of equivalent on a continuous scale. With Pavel, we have worked on this to develop what we call a benchmark. But the idea is that you can say that a 0-1 event, this is the same thing as being below some values on a continuous scale or being above some values on a continuous scale. Thanks to this trick, we have the possibility to derive a joint bivariate normal distribution to jointly model efficacy measured on a continuous outcome and toxicity. They propose to elicit a minimally acceptable biomarker level. And if I had to make a poll, what would be the minimum level of activity of expansion I need to derive clinical activity? I think nobody would be able to come to a good conclusion. So to define this target, would be very difficult in this new treatment that is CAR T-cell. They also define two targets, so the target for the activity, the target for the toxicity, and then you try to select all the dose levels that fulfill those two criteria: acceptable activity and not too toxic. And in 2005, anticipating the Optimus project, the authors proposed to randomize between all those acceptable dose levels. Okay, do we really want to, can we really use this approach? I'm not pretty sure, because for two reasons. The first one, all the information on the biomarker is taken at a single time point. And I don't know when I should look at to know whether or not I have a reasonable expansion. The second thing is that I do not have any idea of what would be the target. The expansion can reach various peaks to have various durations, and we need to define what duration is in this setting. But what triggers the clinical activity, so the response, the long PFS, is largely unknown. Is it the minimum level of expansion, so how high you reach the peak, the time at which the peak is reached, or how long duration of response should be? We have no idea, and that is why we propose to work on all three possibilities. But what we know is that the trajectory, the value of CAR T-cell over time summarizes or enables to draw any of those three components, and that is why we put efforts into working with repeated measurements of CAR T-cells.
Okay, so based on the observed data from a previous paper and also the clinical opinions, we see that there are three types of the trajectory. So the first type will, So the first type will have the trajectory increase quickly at the beginning, but then very quickly it drops to zero, as exemplified by this yellow curve. The second type of trajectories of interest will increase and then it will maintain high for some time. And finally, the third type would just decrease straight away to zero without the first increasing period, as shown by the green curve. So, and another point to point out is that during the planning stage, we plan to have common measurement to all patients. But then when we really conduct the trial, there could be potential missingness. So for example, at day 0, there is a planned measurement, but only the yellow patient took this measurement and all the other values are missing. So based on these features, we decide to use a bi-exponential model. And this is motivated by the PK/PD information, and it's a good approximation of the ordinary differential equations suggested by the PK/PD models. So in this bi-exponential model, we have two exponentials, as the name suggested. The first exponential would correspond to the expansion period, and the second one would be the decay of the CAR T cells. So that's the efficacy model. And for toxicity, we just use the continual reassessment method introduced at the beginning, where I emphasize again that this model assumes a monotonic dose toxicity relationship, which may or may not be true. So based on this toxicity model, we'll select a set of safe doses, and we will only choose, and among the safe doses, we'll choose the one that maximizes the efficacy. And as just been mentioned, we don't know what is a good criterion to indicate the CAR T activities, and therefore we consider 3 potential criteria based on which we'll escalate. So the first criterion considers the height of the peak. So what we do is we fix a time threshold and we look at the dose which maximize the CAR-T expansion at this specific time. So in this case, it will be the green curve. The second potential criteria will look at the duration such that the trajectory go beyond this that threshold. And finally, the third threshold look at the area under the curve, which sort of combine the first two dimensions. So based on this, the design will go in the following ways. Firstly, we enroll the first cohort of patients to the lowest dose level, and then we feed the toxicity model, which was the CRM, and based on that, we found a set of safe doses. Then among the safe doses, we feed the efficacy model, and then we assign the next cohort of patient, which maximize one of the three escalation criteria that we choose. So we'll repeat steps 2 to 4 until we have enrolled all the patients. We'll evaluate the design using simulations. So in this simulation study, we defined 4 dose levels: 25, 75, 225, and 450 times 10 to the 6. And then the target toxicity level will be 20%, and anything below 30% will be acceptable. So we assume there are 5 cohorts of 2 patients, so in total 10 patients, and the pre-planned common measurement time will be once per week for 14 weeks. So inside the escalation criterion, the time threshold, which was related to the first criterion, is set to 14 days, so 2 weeks. And the Z threshold, so the threshold on the CAR-T expansions, will be the same as the lowest dose level. We will compare the performance of our design with a benchmark that we developed with Paoletti. And this benchmark will essentially give an upper bound of how well the model can possibly perform under any given scenario. So the metric for accuracy will be the proportion of correct selection ratio. So that's the proportion of correct selection of the optimal dose and our proposed model compared to the benchmark. We considered the following scenarios. So for the toxicities, we consider 2 scenarios where in scenario 1, we have all 4 doses being safe. And the scenario 2, the highest dose is not safe, whereas the first 3 are safe. This is based on the CAR-T cells behavior, because we know that in real trials, we rarely see any toxic event. And for the efficacy scenarios, the first one will be the same as what we've suggested in our efficacy model. And in the second efficacy scenario, we added on an extra correlation for repeated measurement for the same patient. And the third efficacy scenario comes from a postulation from clinicians who suggest that there might be 2 subpopulations among the patient. So the first population will have the initial increase before the decay, and the second subpopulation will not have this expansion. So, and therefore we use this indicator to generate patients from 2 different populations and mix them. And finally, the last scenario would directly take the data from observed data that has been reported from this paper, and we add random noise to the observed data. So just as an example, this is the mean efficacy trajectory under scenario 1 and 2. And this is the one under the third scenario. We had 2 subpopulations, so one with the expansion and one without. And by the way, the 4 colors corresponds to the 4 dose levels. And finally, we have the last scenario where this is the reported observed data of the expansion, and we will add on random noises on top of that. So together with the 2 toxicity scenarios, we have 8 scenarios that I plot on the y-axis, And on the x-axis, these are the PCS ratios of our design compared to the benchmark. So this is a quite busy plot. So firstly, the three colors correspond to the three escalation criteria. So the blue one looks at the height of the peak. The orange one looks at the duration of the expansion, and the blue one looks at the area under the curve. So it's a combination of the two dimensions. So the first message we see from this plot is that not all of the three escalation criteria are robust under different scenarios. So as an example, the purple ones is more robust than the orange ones, for example. And then this dot that is close to 1 corresponds to a very good performance, because this gives the same accuracy as the benchmark, whereas the benchmark gives the highest potential performance. So anything close to 1 is good. So we see that we have 2 dots which correspond to some super efficiency that's potentially due to some bias of the design. And then we have the mean points which are close to 1, and this indicates good performance. But also we have this poor performance. So now we'll look at this poor performance one by one. So firstly, this green dot. So this green dot is under the toxicity scenario 1, where we have all 4 doses being safe, and the efficacy scenario 4, where we simulate the data from the observed data and we add on noise. This C1 criterion looks at the height of the peak. So in these figures, I just show the fitted model cohort by cohort. So in the solid lines, I have the truth, and in the dashed lines, I have the fitted curves. As you can see that the fitting is not as good. What's the reason is because the true observed data has sort of 1 peak and then a second peak, whereas in our model, we could only have at most 1 peak. So that's the reason that we don't have a very good fitting under this criterion. And then the second case where we don't have a good performance is under T1E3, where all 4 doses are safe and the data are generated from 2 subpopulations. Criterion C2 looks at the duration of the expansion. And the reason that we don't have a good accuracy is because we choose this threshold to be exactly equal to the lowest dose level, and therefore it is hard to distinct the signal with the noise. So we've also tried with more simulations that we move this threshold slightly above or lower than D1, and immediately the performance gets really, really good, and the PCS was close to 100%. And the final scenario where we don't have a very good performance was T1E3 and the area under the curve criterion. So this was essentially because our efficacy model deemed the highest dose to be unsafe, whereas the highest dose is, in this case, our optimal dose, and it is actually safe. And the reason for this could potentially be that the CRM model does not work very well, because we know that the CRM will work well only when we have more and more patients concentrated at MTD. But here, we don't have that. So with that, I'll summarize the proposed model. So first of all, we've shown by the first part of this talk that we do need an early phase design that is specifically for the CAR T cells.
The second point is that we need endpoints that are sensitive enough. I do not think that CAR T cell expansion is a surrogate marker of PFS or overall survival. But what I expect from CAR T cell is to give me the possibility to rank the doses. So what I hope, and has not been demonstrated so far, is that if I have a better expansion, I will not have a worse clinical activity. due to the mechanism of action. But this is a strong assumption. But this is at this cost that we could make clinical trials with only 15 patients and still be able to try to sort out between 3 or 4 doses what is the one that we would like to push in phase 2 or possibly phase 3.
And then something that we could do as a further point is that we've seen that our bi-exponential model can only have a single expansion. But then from what we've seen from the observed data, there could be a potential double expansion. And therefore, we might have the proposed model might not be flexible enough to model that.
Which raises also the question of, do we need a landmark? So do we need to capture the very first part, which corresponds to some decline of the infused cells before they start multiplying? So do we need to wait for a few days? And more generally, what are the thresholds and what is a good criteria? There are debates in the literature between physicians. We start to have some databases of approved CAR T cells because in hematological center, at least in France, they tend to monitor the CAR T cell expansion for all the patients who receive CAR T cells in a healthcare setting, so after approval. So far, to access this data is a bit difficult because people love to share that data. But I think that we will, in a few months or few years, have access to those databases in order to try to really see what is the criteria that it is the most associated with clinical outcomes.
Yeah, and finally, we've seen that when we use the CRM to model the toxicity, it might not be well adapted when the patients are not all allocated to the best estimate of the MTD, and therefore we might consider other models that can do a non-monotonic relationship, and that's it. Here are the references.
Thank you very much for your attention.